Good morning, and thank you for being with us on Daybreak this morning. Health and lifestyle begins right now. And today, the topic that we want to explore is something that I believe almost everybody who has interacted with a health facility has either heard about or has been part and parcel of. Have you ever come across or heard about, somebody who has suffered or is still suffering from what is called medical negligence? It could be even yourself. You suffered or you're still suffering. You have like the complications that resulted from an experience you had at a medical facility. And have you ever just went to a medical facility and had reservations about how you were handled or the kind of care that you received? Did you complain? How did you complain? What was done about it? Those are some of the questions that we will be exploring with my panelists this morning as we talk about what is called medical negligence. And I have with me a panel that cuts across. From my far right, we are glad to have Dr. David Kariuki. He is the CEO of the Kenya Medical Practitioners and Dentists Council, KMPDC. Asante for creating time this morning. And we have with us Stella Muraguri. Stella is a managing partner, MMV Advocates. Thank you for creating time as well. And we have with us Dr. Kahura Mundia. He's the Deputy National Chairperson of the Kenya Medical Practitioners and Dentists Union, KMPDU. But most importantly, he's also the president of the Kenya Dentists Association. Asante Daktari for creating time. I want us to talk about medical negligence and really break it down for Kenyans to understand what it's all about and what one needs to do to even have a case that meets the threshold in case they are a victim. But let's begin here. Let's explore a case that is still currently under investigation. It's a 17-year-old girl who left home and went to a medical facility in Kariobangi. And when we covered the story about her, she was, undergoing severe wounds as a result of the kind of care she received at this specific facility. I want us to hear more about what she said concerning her predicament. Her name is Tracy. And then maybe that will help us inroad into this conversation because many Kenyans could relate with what this lady went through. Let's listen into that.
Fika Albasra wakaniambia nafaa kuingia theater ati appendix imeoza and it's an emergency. Kupelekwa emergency room, mama kusaini kitu, nikaingia tu direct, nishaingia nishaanza operation. That was the first operation of which ilienda vibaya. Nikakaa 5 days without doing the dressing and stuff. Nikaoza. Wakanifanyia operation ya pili of which bado ikaenda vibaya. Any time walikuwa wanafanya hiyo dressing, walikuwa wananikata the wound ikabaki nje. Operation ya pili nilifanya na pupu na hapa.
The patient was very sick, had abdominal infection as well. Everything possible was done to control the infection. That was the main problem at that particular time.
Sasa niko hapa kwa sababu hao watu walitampa na mimi. Niko hospitali and I should be in school. That thing is really tampering with me. Hapa niko na uchungu kabisa. Kwa sababu anytime I'm not in any medication, like hiyo uchungu ikikam, I really regret why I was really born in this life. Those guys that really tampered with my life, wameniumiza, wamenikata, like I can't eat a very good meal kwa sababu nimefanya operation. Wameniumiza. If only you guys you can help me, hospitali ifungwe, sitaki mtu mwingine umie kama mimi.
All right, and Tracy's experience is one that many Kenyans out there relate to. Some have not even gotten the opportunity to come out in public and share their predicament. And let me, in the interest of just this particular case, Dr. Kariuki, let me get to hear your thoughts. This was one of the cases that was under investigation by your council. Maybe just to get to hear what has transpired, what we know about it so far, what has happened with this specific one before we open up the conversation for discussion.
Thank you very much first for welcoming us here. The Kenya Medical Practitioners Dentists Council basically exists to protect the public from harm when they are accessing healthcare services. And secondly, to guide the professionals as they provide services so that they provide them in a manner that is beneficial to the patients and the public at large. In this particular case, yes, we are actively investigating it, so maybe we can only be able to give what is available publicly, that yes, once it got to us, we took action and the patient was moved to Kenyatta National Hospital, where they are undertaking, more treatment to ensure that she gets well soonest. We also asked them, as part of procedure for the family, to now formally complain. Normally we undertake investigations in two ways. We can undertake investigation as public interest, because it is in the interest of the public to ensure that all facilities are providing quality standard health care. We also now undertake, where there is a formal complaint by a patient or their family, to be able to have the council take due process and confirm whether there is negligence or not. And that's what we are doing in this case. Yes.
In terms of the facility, has there been anything that has been done?
Yes, we did get to the facility, because that's the first point of call, to know what happened and what has been transpiring. And we've taken several corrective actions against that facility. Yes.
Anything specific that you can share with us?
Against their practitioners and against the hospital itself. I think probably because of some bit of confidentiality, we may not be able to maybe give a lot of details for now, but we've done quite a lot of actions against the facility. And again, they are still appearing before the council. Yes.
All right.
Right.
All right. At least there's assurance that there is action that is being taken and the case is under investigation. But Stella is the managing partner of MMW Advocates. You deal a lot with such cases. The traffic of such cases, is quite overwhelming. You can correct me if I'm wrong. But when you hear such, what Tracy was sharing and how she spoke her heart out about how even her future looks like as a young woman, what gaps are you reading or identifying from this particular incident that probably would speak to the bigger picture of how things are done in this part of the world?
Okay, thank you so much for having us. First, I must say that there has been a rise in medical negligence cases. As a matter of fact, I would say 2024, 2025, we were getting maybe 2 to 3 cases a week where we're just getting queries where people are asking, these are my facts, these are my circumstances, the hospital I went to. Is there a case here? Now, it is important to distinguish that sometimes mistakes happen, but mistakes are not the same as medical negligence, right? And explaining medical negligence to the masses is something that is extremely pivotal, so that then it is understood that, is this conduct acceptable? Because what we're looking at when it comes to medical negligence is that, number one, a doctor or a health facility has a duty of care to treat you and treat you according to the acceptable standards. So, as a matter of fact, in the UK and Europe, they have moved it from medical care to medical negligence to clinical negligence. So then they can include clinics, medical officers, pharmacists, and so on and so forth, not just doctors and hospitals. So is there a duty of care? The moment a doctor accepts, a hospital agrees to treat you, there is a duty of care that has been created. And then is there a breach of that duty of care? So already we've established in her case there is a duty of care. Now, breach when it comes to duty of care is, would other doctors looking at the same circumstance say that how she was treated, looking at the medical notes, at the medical records, would they say that this lady was actually treated in the acceptable manner and in according to the standards they have set out as doctors? So that's called reasonable care. And it's important to understand that the skill that a doctor has and my perception may not be the same. So what I consider reasonable as an ordinary man is not what Daktari would consider as reasonable. So then we look at that. And then we look at, she has complained that there is an injury or a harm. Is that injury occasioned by the surgery she went through or the procedure she went through? Because you can say that, yes, there is an injury, but is it directly linked to the process or procedure she went through. And then after that, now we look at what is the damage. Because from hearing her, you are looking at potentially medical bills. You're looking at bills in terms of her medication. You are looking at loss of quality in terms of diminished quality in terms of her life, assuming there is a correlation. You're looking at even future medical costs, and those are some of the things that the court then will award. But all these particular hurdles must first be passed for us to say then, yes, one, those are medical negligence. It's not a mistake, it is actually negligent. It was not it's not a foreseeable risk, it is, again, negligent. And then now we can talk about what award can she get, and so on and so forth.
All right. Dr. I know in your profession, there is just trying to listen to what even she said about the duty of care. Times in your profession, you can do something to perform maybe a procedure or offer a service that in your judgment is the best that the patient could have received. Of course, you may not at all times guarantee positive outcomes, but then in the end, you find that the patient is not at home with that particular procedure. So how do you navigate such complexities? And how do you, in your profession, also ensure that cases such as what we're talking about, medical negligence, are curtailed?
Thank you, Safin. Firstly, I'd want to sympathize with Ms. Tracy for whatever she's gone through. And it's not what everyone, or even myself, I'd want to go through as a patient or as a doctor. And as doctors, we are trained to offer the best kind of care. And the Constitution actually also highlights the same, that everyone deserves the highest attainable standard of care. So what we are supposed to do as doctors is to offer you the whole experience from the time you set into the hospital. So the doctors or the clinicians who are attending to the patients ideally should explain the whole journey, how it is like, before even the processes are done. So if there happen to be sometimes issues of communications towards how it is supposed to be done, or what kind of complications could arise, they are not disclosed, then sometimes that kind of miscommunication results to an issue at the end of the procedures. And then the complications now turn out to be something that needs to be explained to, the patients are unhappy, and that needs to be settled. So what I would want to probably talk to my doctors as well as the patients, we belong to the same side. So if the system is not working, the system is now either the hospital where the doctor is working or where the patient is at. If it's not well equipped, if it's not well resourced by persons with the necessary skills, then events can happen. So if we have good communication, enough staffing, and enough equipment that is required for the procedures, and everything is all laid out before the surgeries or before the procedures happen, then the chances of this happening becomes very low. So it's a journey of trying to correct so that we get to have better systems serving us. So that's what I'd want to talk about, that we want to do the best as doctors, and our work is to make sure that patients are comfortable. So if such an eventuality happened to Ms. Tracy, as we've been told, the matter is still undergoing investigations. We'd want to know what really went on. Was the doctor well qualified? Was the consent well taken off? Was it a foreseeable complication that happened? And is it correctable? So, but the unfortunate bit is now the patient has to suffer extra bills. So that's the pain part, which must be solved.
Yeah. And there's no guarantee that, you know, it could be fixed. You know, it's just a possibility, staying optimistic. But then how many such cases, Dr. Kariuki, do you... But this is just one of the cases that is currently under investigation. Paint a picture for us about the cases of medical negligence that probably you receive as a council, and what this means for you as the people who have the mandate. You said public interest was your key goal. How many cases do you receive? She gave us 2 to 3 cases per week. That was in 2024, 2025. But from your end as well, are there numbers that we can work with, we can look at?
Yes, at the council last year we received 130 cases.
That was the whole year? For the whole year.
And they've been kind of fluctuating around there between 100 to 130 over the last 5 or so years. This is probably out of the over 2 million visits that are, recorded countrywide. So we believe probably with a bit more awareness, we may get more questions about people asking us to check and consider whether the treatment they received was reasonably good or there could have been errors in one place or the other. And I think it's part of why we are also here to be able to create awareness to the public on what they can do whenever they feel that they have questions around the care that they have received.
You said 2 million visits?
Over 2 million outpatient visits in the country per year. Admissions are maybe much less, maybe in the tens of thousands.
But it doesn't mean that the 100 cases you receive is insignificant.
Yes. No, they are not. You know, every single case is significant because that's a person we are talking about. Yeah. So every case is significant. Yeah. Only that we are, maybe those figures just indicate that we are doing well, and that maybe the health professionals trained in this country are well trained to provide good care. But there are instances where the level of care may be questioned, and that's what we now do when cases are brought before us or when issues arise like what we have seen. Yes.
What are the key concerns for the council in some of the cases that you have dealt with? He talked about looking at the qualification of the doctor, looking at the facility, looking at different aspects of what makes a case of medical negligence. From your end, what do you see that concerns you as a council in terms of trends?
Yes, quickly, I think the process that is usually undertaken is that once we receive a complaint, we, together with the client who has, or the patient who has brought it before us, go through the documentation that they have. And we then determine whether it's something that is worth following through or is something that can be, completed at that point. It may be that what they wanted was just answers about, something about the care that they got, and that can be got immediately. But where we think that now we need to know more despite the documentation that we have received, we then now formally, start the process. And the process starts by, us asking the doctor or the health facility where the person was treated to provide, documentation. And by law, we ask for the complete file that the patient was treated with, from when they were an outpatient to an inpatient, and even for follow-up, certified copies of that. And then from there, we ask the client also, because we also ask the facility and the doctor to write statements on what the patient has complained about. And once they give us that, we are able to give both the patient and the doctor each person's, documents, so that they can also now probably provide more information on what exactly transpired. With that, we then provide these documents to a health professional of equal skill. Yeah. Because the issue here, as Wakili said, is that the first thing is that we establish there was a patient-doctor or patient-hospital relationship. Once that, then it means that now there was a duty of care between the two. There is one who is the patient who had legitimate expectations that they will get, the kind of care that they would expect. So why we then determine what kind of speciality the patient was being treated under. And those documents are then subjected to the professionals in that area who give their opinion, because against the expected reasonable standard of care. There are national guidelines on treatment. There are international guidelines on treatment of certain illnesses. So it is checked against those standards. If this particular specialist was the same one to be given that patient, would they have done the same, or is there something they would have done differently? Right.
Out of the 100 plus cases annually, can you give us a ratio of how many are then confirmed to be cases of medical negligence, so that we understand how big a problem we are talking about?
I would say in most instances where we say that there is merit, I would say maybe 30-40%.
30-40%.
Yeah.
All right. You had started by, Stella, by telling us about what sort of I would call meets the threshold of what would be described as medical negligence. I'm looking at these numbers and I'm tempted to also go the direction of, first of all, with the 100, this excludes those who've not even gotten the confidence to complain. It also excludes those who probably didn't have the know-how on how they can better defend their cases. Probably just a quick comment on whether, first of all, Kenyans know that they can sue for medical negligence, and if yes, do they even know how to go about it?
Okay.
Yeah.
You know, as Dr. was speaking, I thought to myself that 130 reports made per year is not indicative of the number of potential negligent cases that have been there. So those are two
different things.
Those are two separate things. It's just that it's 130 people who are willing and ready to go forward and report. So it is not a proper indicative number to actually suggest or propose or say that the profession is good or it's above board. And similarly, when we say 30 to 40, which then tells us 40%, 40% means 40 people's lives, families, that are actually ruined because of negligence. Now, I believe part of the reason there has been a slow uptake in terms of reporting is because of the psychological trauma that is there, and two, the complexity that comes with medicine, and then now bring in medical law, and also the number of practitioners who have capacity to handle that. Now, one, when it comes to psychological trauma, it means that when a patient reports, they are reliving that trauma over and over again. We have had cases where our clients come, but you find that the wife is not ready to actually go forward with the matter, but the husband is still willing, particularly with issues to do with delivery of childbirth cases, labor-related issues, or where parents have lost kids because of medical negligence, or issues to do with misdiagnosis, where they feel like, I'm reliving this experience again by reporting it. I'd want to just move on. So there's that psychological trauma that comes with reporting. And then also there's the awareness element. Remember I said that medicine already is a very complex area. When you're going to a doctor, you're going because you have a problem and you believe that they have the capacity to treat you. So it is very difficult to establish, was this unexpected risk or was this actually negligence? And that is why, even as lawyers, we work with medical experts, so that then we are able to then establish, when you look at the medical records, does this meet the standard of care, or is this acceptable? Would you have done the same thing? Would you have been given this patient? Would you have done the same thing? So it's also the complexity of it. But it doesn't mean that Kenyans are less aware, but we are increasingly getting there. And then now, if we look at how slow the process is, right? If you actually file a complaint with the council, you're looking at matters taking years to be resolved. One of the things that I was hoping he would actually say is, how many cases are completed a year? So that then that is what drives confidence. I wish there was a report where we could actually go and say that 130 cases are filed, and in a year, it takes X number of days to actually have it completed. If there was that kind of transparency, then it would mean that there's confidence in reporting, right? And similarly, there are matters that I have filed before the council, and to date, I still do not know the way forward. Then now add on to the judiciary element, because there are complaints that are made to the council, and then there are also cases that are filed in court.
Okay.
Yes.
Maybe you can respond to that, Daktari, before the process and how long it takes. And the reason I was asking you to sieve for us the number 130 something per year and how many are confirmed is because I wanted us to really get it clear. How many cases then are we positive, for lack of a better term, cases are we dealing with? Maybe you can respond to the issue she has raised.
Yes.
Cases that go to conclusion, do we have?
We have received a total of 1,700 cases over the last several years. Of these, only 350 or so remain to be concluded. So 1,400 are already concluded. One of the major issues we get, and it's good that our wakili is here, is the back and forth between the two parties in terms of completing all the documentation that is required to now start making the final, the final ruling in terms of whether there was merit in the complaint or not. Because every time that documents are shared between the two groups, there will always be some counter in terms of there is this document still not available, there is the other document, and that takes a bit of time, because any time that documents are moved from one party to the other, they are given, like 14 to 21 days. Some may not give them back in that time. That's part of what, actually the major cause of delay is the availability of complete documentation. Mm-hmm. You'll find that once we have all the documentation required, professional review most of the times will take also another 2, maximum 21 days. And then from there, if there is going to be requirement for maybe what we call hearings, because everyone must be given an opportunity to fully explain themselves.
So ideally it should take 21 days?
For getting the documentation. So the whole process...
How long should a case take?
The whole process usually takes up to 9 months between the to and fro. Mm-hmm. We actually want to take it to that. Previously it was about 2 years, and now we are bringing it down so that we can complete the whole process within the shortest time. Right.
Dr. Mundia, I don't know what your concerns also would be with regards to how this issue of medical negligence has been defined, especially considering the fact that in I think everywhere, not just in Kenya, the patient has a right for a second opinion, a third, or even a fourth opinion. And in the realm of treatment, professionals have different opinions and different judgment on how best a procedure or a service can be offered. I'm just trying to imagine how complex then it gets when she said that they work with even professionals to really deal with some of these cases. So what if what Dr. A did, in their judgment, that was the best? Then in investigating this case, Dr. B and C says something contrary. How do you deal with those complexities as a professional?
Well, what I would say, the practice of medicine is quite complex. And we all as doctors are trained the same standard, trained the same way of doing things and analysis and diagnosis. But there can be those small variances that could happen, either because a few things have missed in the process of care. And if that happens, then there can be those outcomes that are likely to show up in the course of service delivery. So, but ideally, a doctor who's well-resourced with the adequate CT scans, adequate ultrasound machines, and adequate lab resources to check on whatever is happening, is able to tell the sequence of events that's going on. So when all this is happening, the clinicians will report down all that is seen on the patient diagnosis stage. And then the treatment is discussed with the patient, that this is what you've come with, we found from your report, this is what is likely to be, this is your diagnosis, this will be your treatment. So your treatment entails either taking medications or surgery. So there are usually like two routes, conditions that can be treated by drugs and conditions that will require surgery, or require both. So that is explained to the patient. So when the communication at that stage is well done, then the patient gets to understand what is supposed to be going through. Then the doctor will also, or the clinician will suggest, if you'd want us to take time, we can either begin with this, or some patients feel a little bit hesitant. They feel like I should probably check with another doctor. And it's their right, by the way, to ask another second opinion from any other clinician or another facility as to the sequence of how the diagnosis has been arrived at and where they're supposed to go. So that's their right. Again, it's also the patient's right to get a copy of the records, because our constitution allows patients to get copies of those records to verify whatever is being suggested. So when all this is shared to the patients, trust is built up, because the patient and the doctor are on the same side. The patient wants the best done to them. The doctor wants the best for the patient. So we want to encourage our patients to go with us in the journey of doing the right thing. Sometimes there are failures that happen that are beyond the doctor. By now you find like a facility does not have equipment, and the patient has come in a particular crisis. You've explained, and then with the minimal equipment you've got and the situation that is presenting before you, try to intervene. And then in that intervention, sometimes mistakes can happen. So these mistakes, which are real, sometimes they're real mistakes, if they do happen, then it's not a point of probably trying to see how best to punish either the system for whatever happened, but for the patient and the doctor to come together, They air out whatever has happened, it's reported, it's documented, and we try to cure that not to happen again in the future for other persons to experience the best care. So it's a journey of trying to improve processes. But where there are evident issues, those ones must be.
What I've got from you is the significance of transparency from both the doctor's end and the patient's end. But I want us to shift this conversation and talk about some mistakes that can be averted. For instance, one that happened in a case that we also worked on and did a story around recently. I'd like that brought up. It's a case of a young man, Amos Isoka, I believe majority of you are familiar with this particular case. A young man who walked into a medical facility for a tooth extraction procedure. And after treatment, he developed complications and very overwhelming, swelling on his neck. That was on the chest and also on the tongue. There was a lot that was done to transfer him from that specific facility to yet another one and later to the Kenyatta National Hospital. They tried all they could, but then in the end, he ended up losing his life. And I'm just wondering who loses his life because of a tooth extraction procedure. Many Kenyans have asked that question, but let's listen to what the family had to say after this, and then we can begin to explore the gaps in this particular case.
Wametuambia ati ama ametuacha na mimi sina mtoto mwingine, kila kitu ni Amo, sina kila kitu mimi.
Ndio niliambiwa Amos anafaa fanywe operation ya kifua. Daktari alianza kunieleza vile Amos usiku alikuwa. Akaniambia mapigo ya moyo ya Amos usiku ilikuja ikawa worse kupiga, ikakuja ikastop. Vile ili stop, Amos alienda kupampiwa vile unaweza saidiwa kupumua, lakini kwa bahati mbaya ilishindikana. Amos akatuacha saa 5 usiku.
Who is to blame? This is a systemic failure. Yeah, it's a systemic failure. Yeah, it's all of us. We do carry this blame. Yeah, that's just the truth. All the way from, we do have a strike that is happening in Nairobi County. We do have a facility that wasn't supposed to be there in terms of operations. We do have people who are working in those facilities who should have had licenses. We do have a responsibility for the owners of those places to have had proper people employed.
Those are pertinent issues being raised there, but then who dies from a tooth extraction procedure? You're a dentist? I don't know. This case was one that many were left puzzled about what happened. And first of all, maybe just to start with you, Daktari, when you hear or when you interacted with this particular case, what was your quick thoughts as an association of dentists? We understand that this particular doctor is not even a dentist. How did we get there?
Well, it's very sad that 60 years plus later, we are still having persons lose their lives because of a dental ache. Actually, in the urban centers, it's not supposed to happen. It's something that can happen elsewhere, but not where we are as a country as to what you're supposed to do. So like it's been reported, the facilities out there, some of them are not registered. So in all these concepts of medical negligence, many things happen. There can be facilities that are not registered. There can be persons who are not qualified as doctors doing doctor's work, which is not what's supposed to happen. And then there is the issue of now access to care, whereby the persons are not able to get a real doctor where they are, or maybe the system is not able to allow them to pay for this particular service. Like yesterday, we're following up with SHA. SHA is our social health care insurance. And I want to put it on record again. This is the second year going. SHA is not covering dental care services. And we tried to plead with them yesterday to try to upload a package that at least offer basic care to patients so that they're able to afford and get the best care. So patients are forced to pay out of pocket. When they don't have money, they go look for cheap. And cheap sometimes can be expensive. Someone else out there who's not a doctor will come and say, I can treat you for 100 shillings. I'll do whatever. So they do whatever they do, then they cause you more harm. So again, these facilities, most of these public facilities, they have very few dentists. Very few dentists. So that means access to dental care services becomes a challenge because you're trying to struggle, where do I go? The county governments don't want to resource. They're understaffed, they're short-staffed, they don't even have some places, doctors working. Then the patient is forced to a corner whereby they just have to go to a bad place, something happens. But I'm happy that...
In your judgment, could this death been have been avoided?
It was supposed to be avoidable, because if there was no strike in Nairobi County, the patient probably would go to Mutwini or Mbagathi. And the dentists who are there, the case is managed there well. If the patient was not probably able to access a facility that's not registered, and the wrong clinicians, probably or not clinicians, persons working in there, that should not have happened. So the patient would ideally have gone to the right place, found the real doctor, there is no strike, and they're treated. And if it's a case of referral, the patient is sent to Kenyatta National Hospital for management. That did not happen.
Let me also rope in Dr. Kariuki on this matter. I mean, we understand that this facility had been operating for 3 years without, illegally. That's what came out later. But how come that it was until this story was highlighted that action was taken, or even before the action was taken, that it was realized that this facility was operating illegally? It puzzles many, Daktari.
Illegal clinics is one of the areas that we really follow consistently to ensure that only those that are genuinely able to provide services are providing services to wananchi across the country. And as you realize, this is probably not a one organization issue to be able to resolve, because illegal clinics basically are criminal enterprises. That's what we would say. Like this particular one, where it's just, a cross on the door showing like it's a medical clinic, but in real sense it was not. And even the persons in there were not any trained health professional, as we would say, and are still currently being sought for.
He's still at large?
Yes, so the relevant arm of government that should trace them is working on getting them. So
but how come it took 3 years for the council?
Probably just to explain a bit of what happens.
3 years?
No, to explain a bit of what happens. Most of these people, when they hear that the council or even the county government is in the area, they actually clean up their places, and those places look like normal shops.
But why should they hear? Don't you have a proper way of doing maybe that?
There is. For example, like over the last year, we had visited over 7,500 places. And even this particular one, by the time the morning came, they had already erased their existence. And they end up reopening later. So it's a place we are going back as often as possible. And not that place only, even many others across the country, to be able to ensure that only the right people are providing services to the wananchi in the various places across the country. Yes.
You started by saying your mandate is of public interest. There was one woman who spoke about this case, and what she said really stood out for me. Like, how would I know, as a common wananchi, how would I know that this facility is registered or licensed or not? How would I know? All I know is the pain that I'm going through, and there's a medical facility next door, and I go there to get help. If I become a victim of medical negligence, then it's just unfortunate. But how would I have averted it? But KMPDC ought to have done that, right?
Every facility that you enter, the first thing you should see is their operating license issued by the council. So any facility that does not prominently display it is most likely not a genuine facility, because every genuine facility must display their operating license. If you insist, even the health worker themselves, if you wanted to see their credentials, you should be able to see. We have also now provided avenues for people to confirm whether the facility they are in is a genuine registered facility. Yes, either by text, by getting to our website and such, and probably we'll also come up with other ways to make it easier for people to confirm that the facilities they go to are actually recognized facilities.
But before I get there as a patient, because at that time I'm in pain, I'm sick, maybe it's an emergency, I don't even have the luxury of asking whether this facility is registered or not. What does KMPDC do before we get to this particular point? Run me through your standard ways of operation so that I know how you're preventing and protecting patients from being taken advantage of by selfish people who are money hungry.
Right, that's what I was saying just a few minutes ago, that we do visit these facilities. We visit every facility, ideally once every year or once every 2 years. So like over the last year, we've visited over 7,500. And as we do that, we identify any illegal clinics and close them. If you remember sometime last year in August, we actually gazetted over 1,000 facilities that were illegal. That was a public awareness that that facility purporting to call itself Facility X is actually not a genuine facility, and you should not go back there. And we have even sought additional partnerships with the national government administrative officers through, the chiefs, administrative officers, the county commissioners, the National Police Service, and the county governments to ensure that those that we have identified that should not be providing services continue closing until either they regularize or they get arrested and are actually taken.
Daktari, could this death been averted?
It could have been averted if the person would have gone to, a genuine clinic. I think it's just unfortunate that they ended up in a place where they were not aware that it wasn't the right place to have gone to.
So whose responsibility is it? Is it the patient because he went to the wrong facility that is not licensed?
I think we all have a responsibility. We may not want to put it on one person or the other, because we, as Daktari also mentioned here, is that usually a patient-doctor, patient-healthcare relationship is a dual relationship. It's not a one-person relationship. And every person becomes part of the care. In fact, that's what we always tell patients, that even the treatment that you are being given, you need to accept it. And there's something we call an informed consent, that even as I tell you I need to extract your tooth, you also need to ask why. Isn't there anything else we can do about it, so that the patient-doctor relationship is an issue of mutual, consent.
All right. Stella, just weigh in on I'm looking at the gaps in this particular case, and the big question people are asking, who bears the responsibility for Amos's case and for the many others who have lost their lives? Some are living with lifelong complications as a result of medical negligence. Whose responsibility is it?
As I was listening to Daktari, I am more convinced now than ever that the responsibility does not lie on the patient. From where I sit, there's a duty in law that the council has to ensure that all hospitals, all facilities that are operating and offering health services are actually licensed. You cannot transfer that obligation to the patient, okay? Now, I want to draw comparisons for ease of understanding the school of thought that I come from. When I walk into a bank, I expect that CBK has undertaken its mandate, Central Bank of Kenya has undertaken its mandate to ensure that the bank I walk into is actually licensed. I don't go asking for their licenses before I open a bank account. Similarly, as a patient, I expect that if there's a facility running, surely there's a body that has taken all necessary measures to ensure, proactively actually, to ensure that it is actually licensed, the people operating within it are actually not quacks. If that obligation is transferred to me as a patient, then it means that we are looking at in the next number of years are 600 cases per year, not 130 cases, right? And we must move from that position where it's not to punish doctors or hospitals, it's to remove quacks, it's to bring dignity into the profession, it's to ensure that Article 43(1) of the Constitution, highest attainable standard of care is actually met, that patients are actually operating in a trust system, that it is not someone will open their clinic today and then tomorrow morning it's closed when there is leakage that they'll be coming in. It's proactivity in terms of, okay, so this is the process. We now know that they know when we are coming. How do we modify and iterate to make sure that we are solving this problem, not having a cat and mouse sort of game? Then also, it's important to say, even if you're talking about consent, right? Yes, I consented, for instance, to a surgery. I'm consenting to foreseeable risk. I'm not consenting to negligence. So even when I hear, and I've had so many times, when I cross-examine doctors and they say, but the patient gave us consent and it was informed consent. Informed consent that a surgery may have risk, that a procedure may have risk, but not consent for the doctor to actually misdiagnose, not consent for the doctor to actually conduct or exercise what we'd call negligence. So from what I've had, I do not believe that any patient should believe that they have an obligation, first and foremost, to check. Yes, you can, as a proactive measure, but the highest duty of care first also lies with the council to make sure that we have the right doctors out there. Right. We reduce it then to from 130 to actually 10. That would be the pride. Yes.
Dr. Mundia, I'm pressed for time here, but just your quick comments on also the profession. This big problem of fake doctors, fake professionals, let me say quacks operating within the industry. I mean, why are we talking about this several years later, despite the efforts that have been done to really curtail and clean up the system?
Well, we have a challenge.
We represent a union,
yes,
and an association.
Yes, yes.
Yeah.
We do have a challenge. We do have qualified persons in the field, many of them actually. And there are also persons who are not qualified out there. All of them are trying to make a living. Of course, the ones who want to make the wrong living want to say they had been taught to do particular procedures which probably they were never taught to do. So there's an issue of what we call as a scope of practice, which exists for general practitioners and specialist doctors. So these are the doctors at the higher level, and then the assistants who work with us. So when persons breach or work beyond what they're trained to, issues can happen. So what should happen is that we should have clear scopes of practice, which should be generated through the Director General Office at the Ministry of Health, and enforced by the regulatory bodies, so that persons work within their training and what they're supposed to. That's what the patient is supposed to experience, the best outcome. But now when you have persons not being employed, we have staff shortages, we're having the few who are working getting overburnt because there's a lot of work, and then they buffer that with persons who are not probably trained to that high level, then services access becomes a challenge. So if you look at all of it holistically, get adequate doctors, number of persons, highly skilled persons to provide services, and a clear referral process and a scope of practice that is clear, then work outcomes become clearer and fewer cases happen up. Doctors do not go to cause harm. So it's actually not fair to say that you take consent to cause harm. But when you say this is the procedure we're going to do, I'll tell you the goodness about the procedure that we'll do, because of the other cases that probably persons have operated and how it's likely to show up, and the foreseeable risks that can happen. Then I balance the two, and I wait for you to actually say, this is what I want to do, and let's try and hope that these other complications may not happen. Right. Then the doctor assures the patient that this will not happen. We'll try our best to make sure, and if it does happen, there's still a way that we can try to moderate it so that it doesn't become so bad. All right. And that's why now we do the written consent.
All right. Dr. Kariuki, as we wind up, what do you tell Kenyans who feel that your council has failed the patients? It has not cracked the whip on the illegal facilities that are operating out there. It has not done enough to ensure that the system is clean so that we avert the deaths and the life-threatening complications that patients go through. What would you tell them?
Yep. First, I would want to tell them that the council has not failed. In the beginning, actually, that function was with no one in the country. And then the council now took over that. And as of today, anyone who has provided their documentation for registration and licensing has been taken through the due process to get it done. The issue of having people undertaking illegal services is what we are always on the lookout for, to ensure that only those who are registered and licensed, anyone providing services out of that expected standard is then illegal, is what you now may call a quack. But we do not have professional persons, whether doctors, nurses, and all other healthcare professionals, providing services in recognized health facilities operating illegally. The illegal ones are those people who masquerade basically as trying to portray themselves as health professionals. And even by law, they are dealt with under the criminal code, not under the Medical Act or the Health Act. And we'd want to work together with all Kenyans to ensure that we are all receiving services from qualified health professionals, recognized health facilities. And all the reforms that are being undertaken are to ensure that we are all taking that direction.
Maybe out of curiosity, why does it take 1 year or 2 years for you to do? Within 1 year, that facility could have done enough damage. Why does it take 1 year or 2
The country is vast, and also as we register and license health facilities, there are also conditions that we set for them. There are reporting mechanisms where they should report any adverse outcomes. That is together with the Ministry of Health. They should have standard operating procedures for any actions that they undertake within the facility. And so therefore, there are many mechanisms that we do. Some of the times is that the services are under supervision of the county health department. Yeah, so...
But do you have enough personnel to be at every corner?
We have enough resources to move around the country for whenever we need to. Yes.
Your final thoughts, Stella?
When I listen to all this, I think to any person who visits a particular hospital or a clinic, because even misdiagnosis is a problem, you have the right within the Constitution to the highest attainable standard of care. So that means not mediocre, not somewhat good, but the highest. Now, in the situation or in an instance where you find yourself having not received that level of care, and you can tell, potentially you can easily
as we wind up, Stella,
yes,
for time.
Yes, you can also tell, or you can see that something happened and something that happened was not right. Please do reach out to a lawyer, because you have the right to actually be compensated, or even to just find closure, to find out whether this is something that went wrong, it was a mistake, or was there negligence?
All right, 10 seconds.
Thank you. Well, mine, I would say, is that doctors and patients work in the same field, and we want the best for our patients, and together we'll work to correct the systemic issues and have the best care as what the Constitution should give us. That is what I would want to ask for.
Thank you so much, Dr. Kahura Mundia. He's the Deputy National Chairperson, the Kenya Medical Practitioners and Dentists Union, also the President of the Kenya Dentists Association. I've been also engaging Stella Muraguri, Managing Partner, MMW Advocates, and also Dr. David Kariuki, CEO, Kenya Medical Practitioners and Dentists Council, KMPDC. Thank you, gentlemen and lady, for creating time for us this morning. That's how we wrap it up. Asante sana for watching Health and Lifestyle this particular morning. We do this again next week, Wednesday. My name is Safin Acheng Oma.